What's up, guys? Today I want to talk a little bit about how you can dominate your time in the intensive care unit and how to organize the information that you get about your patients in a quick and efficient manner. Whether you're a nurse, a doctor, a medical student, it doesn't matter. You have to be able to get the information about your patients, get it organized, and transmit that information to other people, whether it be family members of the patients, to other nurses, to other doctors, to your attending as you're presenting on rounds. You have to be able to know how to get the information, how to present it. And I want to present to you today a way that you can organize that information on a day-to-day basis, and so that every day you know where to find that information and to be able to present it in a concise and organized manner when the time comes. For those that don't know me, my name is Paul Gustin. I am a second-year neurosurgery resident. I just finished 3 months in the ICU, 2 in a surgical trauma ICU and 1 in a neuro ICU. And these are some things that I'd like to share with you that I feel like will be helpful during your time in the ICU. I didn't have anybody to really walk me through or come up with any system, so I put together this system, and I want to share it with you so that hopefully it'll save some brain damage to you and helpful so that you can organize information and do your job more quickly and ultimately take care of patients better, because in the end that's our goal here anyway. Hopefully you guys will find this information helpful, and if you hang with me to the end, I'll tell you my number one tool that I used in the trauma bay that I found to be most helpful. So step 1 to be successful in the ICU is to learn the electronic medical record, or EMR. You have to be able to know where to get the information about your patients. It will be a long and arduous process if you don't know how to find the information about your patients. So today I'll give you a little bit of an introduction about the types of information that you need to acquire so that you can present that information and at least give you a general idea. This is not going to be all-encompassing. This is just to help give you an idea of how to set up the information, and you'll find your own special way of how you like to organize the information, but this is just to help get you started. Step 2 is to set up a dashboard or a summaries page. I know that usually there's a landing page with a lot of the medical records, especially I know Cerner and I think Epic does also, where you can set up like a dashboard, and it shows you your most recent vitals, your ins and outs, your lines that you have placed, your most recent lab work over the last 48 hours, any recent imaging, any micro, and current medications. So if you can set up something like that that has like 80% of the information you need all in one place, that will be super helpful. Once you get your dashboard set up, then you have all the information, or at least most of the information, in one place. If not, then you'll have to go digging for it. But if you can set up this template of sorts that I'll share with you, at least you'll know what information you need, and then it'll be up to you just to find out the best place to go and look for that information. Please comment below things that you found helpful during your time in the ICU. I'd love to hear what your experiences were, what things you found helpful. Like I said, this isn't everything you need to know about the ICU. There are some books out there like the ICU book that are very helpful, and there's also a neuro ICU book that is helpful as well. And those are great books. I'm not here to talk about those books today. I'm just trying to help you set up a way to organize the information so that when you come in every day, you know how to get the information that you need about your patients and put it in an organized way so that when someone asks you a question, your eyes know where to go to find that information on a day-to-day. Step 3 really is setting up a piece of paper. It's just a blank sheet of paper, like a piece of copy paper, and you fold it half long ways, so you just have this long strip of paper. And this is helpful for 2 ways. One, it's easy to write when you're next to the computer. If you have a computer on wheels, and you have a little tiny desk, it's easier to write on, at least I thought so. And for 2, it's easy to be able to slide in a white coat pocket, or you can fold it up again into force and slide it in the back pocket of a set of scrubs. and you always have that information with you to reference. If a nurse asks you to do something or you're attending, you can pull out your paper. I have one piece of paper for each individual patient, and I can write down on my to-do list things that I need to follow up on or things to do. So I'll take you through now the setup of how I set up my paper and the different categories.
Basically split up the middle section into thirds and then just write a line along the right third. At the top, I forgot to put it here, but I usually put the room number and with a circle around it and then the patient's name, 72-year-old male. This is a totally hypothetical situation. This is not a real person, but just to illustrate. And then a history of CHF, hypertension, CKD, whatever. And then I'll usually put their chief complaint. So this guy, he fell downstairs, like what brought them into the hospital, and then kind of just a quick what happened after that. And so this guy, he was scanned, found to have epidural hematoma, and he was taken for a cranie on the 1st. And then I usually write on the top line overnight events, OE. And so for here, let's say he had a temperature max of 38.2 and his blood pressure was a little elevated to 190 over 100. So I'll add that in. And then if he's intubated, I usually have an I with a circle around it. And for sedation, he's if he's not on any sedation, then I'll put an X through it. If he is on sedation, I'll just leave an S with a circle around it. And you'll see that I abbreviate a lot. And the more you can abbreviate and still know what you're doing, the faster you're going to be. So for my patient, he's currently afebrile, so I always put a circle with a line through it for temperature. Afebrile, 87 heart rate, 14 respers, 100% sats. His blood pressure right now is 118 over 68. He's on assist control, so I know he's ventilated. 16 500, 40% 5. 16 is the respiratory rate, 500 is the tidal volume, 5 a PEEP, 40% oxygen. And then I always will put the most recent AVG right below that if they're intubated. If they're not, instead of the AC, I'll just put a RA for room air, or I'll put like 6L NC for like 6 liters nasal cannula. And that really just kind of sums up the vitals section. For some reason, I just like doing this little L like this because the ins and outs ended up being, it would show me the day before, and I just wanted a way to distinguish between like yesterday's total ins and outs and today's, since really today's wasn't documented. So I do this little L so I know anything on the right is from yesterday, anything on the left is from today. So in this patient, let's say 3771 in and 895 out. Usually the attendings didn't really care about how it got in, they just want to know what's coming out. And so 845 of urine, so I have a U with a circle around it and a JP drain. From the head, put out 50, and then I'll put a slash, and then I put whatever lines are in. So this guy had a right IJ, and he had a right arterial line, and an NG tube. So you can see all those abbreviations, RIJ, RA, NGT. And then the next section is going to be all the lab work. Sodium, elevated. I put a little hat on the top if it's elevated, or I'll just draw a separate arrow down or up, depending on what it is. And you can see the chemistries right there. And then I'll do for calcium, magnesium, phos, I just like doing it like this because it fits nicely. And then for like the rest of the CMP, like liver enzymes, if they're all normal and we had been checking this patients for a number of days, they're still normal. Sometimes I'll just do a little squiggly line, and I know what normally goes there, and a squiggly line to me means they're normal. Sometimes even with the chemistries, I'll just do a squiggly kind of with a little tail on the end, and I know that's all normal. All the values were within normal limits. And so anyway, so here's the CBC info. I'll put that there. You see the hemoglobin on top, 6.9. If anything's abnormal, usually I like to see where it was at before. So here I write off to the side 6.0, so I know it's trending up and getting better. And sometimes I'll even write next to it kind of a little curved up arrow to know that it's trending up, or a curved down arrow to know that it's trending down. And then you'll see the coags. I didn't get a PT or INR, but I did get PTT, and that was 36, which is high, but this patient's on a heparin drip. Which is not the same patient, because you wouldn't want to put epidural hematoma on a heparin drip, but this is just to give you an idea. I think this was another vascular patient or something like that we had on a heparin drip. But anyway, obviously it's not all going to make sense, but just an example to show you how I would put it if for some reason the patient was on a heparin drip. The next section was imaging, so repeat CT head was a S with a circle around it for stable, chest x-ray was negative. Next section was micro, blood cultures are negative times 2 days. And then you see FENAD, and then PPX, ABX, that's just the way I did it. Normal saline at 125, also on propofol and fentanyl, which doesn't really, go with the top where it says no sedation. Obviously this is just a hypothetical situation. E is, so F is for fluids, but I also put like drips in there. E, electrolytes, watch the K+, whatever. Nutrition for N, NPO, activity for A, bed rest. D, dispo, keeping the ICU. PPX, prophylaxis, so, let's say Lovenox or heparin, for the heparin drip. Or also sometimes I'll put in there under prophylaxis, I'll put like seizure prophylaxis, I'll put a K for Keppra with a circle around it, or like famotidine, or Pepsid, those kind of, for GI prophylaxis and antibiotics, ANSEF, that kind of thing. So you'll see actually to the right, when after I do the FENAD, PPX, ABX, then I'll put, usually it doesn't take up all that much space, and I'll have room to write medications, and you don't have to write every single medication, but just like the big ones, if they're on phenytoin, for seizure prophylaxis, Lasix, clonidine, propranolol, and this is really, it's really helpful if you can learn how to abbreviate these things, and usually I don't put the dosages on if it, I know what the standard dose is for Keppra, okay, we're gonna do 500 BID, I don't need to write that every time, I just put a K with a circle around it, I don't need to write it all out, I know he's on, the standard dose. If it's something different, then I'll try to write it. You can waste a lot of time writing down every single medication, especially if you can just click a few buttons on the computer while you're rounding if they want to know, if the attending wants to know a specific medication or something like that. And once again, like I said, all the way on the right side, that ends up being your to-do list or things to follow up on at the top. So follow up EEG, follow up repeat CT head read, or replete K+, replete the potassium. And now the bottom, like I would do Excel, so update the Excel spreadsheet that we use for our sign out, reorder labs for the next morning, including chest X-ray or ABG on anybody that's intubated. Usually I'll check that every day. And then just a little reminder to make sure I wrote the note for the day, the progress note. And then all the way at the bottom, I do a S with a circle around it. You'll see S means lots of different things for me. This is subjective, and then /O for objective. So this, when I go around and actually see the patient, I can just scribble down a couple notes. Okay, this patient's intubated, unresponsive. He's a GCS of 1T2, so he's a 4T, and he's got some dyscerebrate posturing, obviously, from the 2, and he's got positive corneals, cough, no gag. And that kind of thing. So it's just a quick and simple way, where you can write down some notes as you're going around, and you can kind of write what their subjective is. Oh, they feel great today, everything's good, passing gas, had a bowel movement, that kind of thing, or unresponsive and intubated, sedated, whatever. And then put your objective findings there. And as you're going through these this data, if you notice anything that's kind of out of whack, you can always write, follow up, like the potassium or whatever is low, follow up in your to-do list. And what I'll also do is carry a highlighter, and I'll actually highlight anything that's abnormal that I definitely want to make sure I talk about with the attending, like overnight events, they spiked a fever 38.2, or AC, they're on assist control, they're on the vent, these are the vent settings, they're definitely intubated, here's the most recent ABG, so I can talk about that if that's abnormal, that kind of thing. If they still have a JP drain, usually want to know what that's putting out. And then any abnormal of the chemistries, I'll kind of highlight that. Hemoglobin 6.9, want to keep an eye on that. There's the PTT, want to keep an eye on that. Talk about the repeat CT head that was stable, and know that the blood cultures are negative times 2 days. And they're on propofin, that kind of thing. So anyway, with this kind of layout, you can really just have your whole story in line. And then I didn't put it on here. Some people like to actually break down the different systems on their little note here. I would prepare the actual progress note ahead of time and have the neuro, HENT, CV, pulm, GI, GU, heme, ID, musculoskeletal, those different categories already. And so I could kind of, once I got done seeing the patient, then I go in and start the note, and then just anything that I highlighted or that was abnormal, then I go through each one of the sections and add that relative portion to that area. So most attendings were like, don't tell me about any of the labs unless it was relevant, like, oh, okay, his sodium, for neuro status, he's on 3% sodium. With his last sodium, I was 149, the goal is 150 to 155. That kind of thing. So just kind of talk about the relative things when the time came up under the different systems. But the top part's really helpful because really it'd be like, okay, we got bed 17 here. This is Mr. Barker. He's a 72-year-old male with a history of CHF, hypertension, CKD. He came in the hospital because he fell down some stairs, bumped his head, got an epidural hematoma on the right side or whatever, was taken emergently for a cranie.
Number one tool that I loved and used all the time when I went down to the trauma bay was this pair of shears right here. This is the Leatherman Raptor shears, and they open just like this, and these were amazing. They would cut through anything. I'm going to do a review about these later. Thanks for watching, guys. Like, subscribe, follow, comment with anything. We'll see you on the next one.